Hello, welcome to the Illinois Prescription Monitoring Safe Opioid Prescribing Program. My name is June Oliver. I'm an advanced practice nurse with pain management and have been practicing in that field for 23 years. And I'm happy to be here with you to share important information about how to assess pain and then later in the program, further information on treating pain. So, what are our learning objectives today? In this section, we're going to discuss the need for comprehensive pain education. We're going to define the types and physiologic mechanisms of pain and outline comprehensive and holistic assessment and screening approaches for patients with pain. It's a lot of information, but it will be useful, and all providers of healthcare are really pain management providers, as it's such a common need and complaint when patients seek healthcare. In that same idea, what is the need for pain management education? Why are we here today? The foundation for answering that question lies in understanding the tale of two crises. There is pain and there is overdose of opioids. Often those two problems are polarized, publicized widely, and politicized. To look at the dual crisis of overdose and pain, what then is the prevalence and cost of pain? The National Health Interview Survey from 2022 lists 50.2 million adults. That's 25% or 1 in 5 of adults in the U.S. live with pain every or most days, and half of that, about 24.4 million, which is 10% of the population of adults, have what's called high-impact chronic pain that limits physical, social functioning, as well as employment, with many more days of work missed when that high-impact chronic pain exists. Societal costs are also very high. Back in 2011, the Institute of Medicine's report on pain listed $299 to $335 billion of cost per year related to pain. In 2022, the estimate is not much different, $296 billion per year. So 70,000 people dying of opioid overdose versus 50.2 million with pain or 24 million with high impact pain. The numbers are significantly different. Every life is valuable. The overdose situation needs attention. We don't want it to escalate. We want to bring it down, but we have to put it in its correct context. So what is our goal given all this information? Well, safe, effective pain management, which almost nobody will argue with, but how do we get there? So it's both and, not either or, is the first foundational principle to keep in mind. So safety in general is supported by an individualistic, holistic assessment and a biopsychosocial spiritual components being examined, including function and quality of life. And we look to identify individual risk factors for any treatment plan that we're providing for a patient, including things like medication side effects. We also look for risk factors for misuse of medications, opioids included, and substance use disorder, which can apply to a number of substances, opioids as one of them. And so we need to, in safety management, weigh the risks and the benefits of treating pain, but we also need to remember to weigh the risks and benefits of not treating pain, particularly if opioids are omitted. What does that do to the risk and benefit of treating and non-treating pain? Effectiveness, we need a knowledgeable provider, and again, we need individual holistic assessment with that biopsychosocial, spiritual components, including function. So what is the physiologic cost of severe pain? A look below the surface. There are many physiologic effects that are often discounted but documented in the literature. Hypercoagulability with severe pain, likely related to a stress hormone that is chronically elevated, as well as poor mobility that we often see with severe pain. Immune suppression, the number of natural killer cells goes down with chronic severe pain, and we find that severe pain with cancer patients is actually tumor enhancing. Tumor growth is promoted when pain is not controlled. There's an HPA axis cortisol release that can alter glucagon secretion as well as insulin and actually promote a hypermetabolic state. There can be increased salt and water retention, again related to cortisol, and then our renin-angiotensin-aldosterone activation, which is going to affect sodium as well as potentially vital signs. Persistent catabolism has been linked with severe pain, muscle breakdown, weakness, poor healing, and decreased GI motility. Pain and opioids both decrease bowel function, which is something to keep in mind, particularly with post-op patients where they may have some delay in return of GI motility, but also if they have severe pain, sometimes they're instructed, don't use the pain medicine. We got to get your bowels moving. That betrays a lack of understanding that severe pain as a sympathetic stimulator also decreases GI motility. So we have to find a balance. Just not using the opioids in the presence of severe pain is not going to help GI motility return. And of course, poor sleep and recovery. What are mental health linkages to pain? So we know that depression and anxiety often co-occur with pain. Patients with chronic pain may have up to 65% in that population with concurrent anxiety and 83% with concurrent depression. And also, to varying degrees, but in significantly high rates, we find patients with substance use disorder having mood and anxiety diagnoses as well. It's important to remember this is a bidirectional effect, meaning pain and mental health affect each other almost in a circular fashion. So the physical and mental emotional pain exacerbate and contribute to each other. So we can't just say we're going to treat the body, because if the mind and the emotions are also, quote, in pain, we're not going to be effective and we may miss the mark significantly. We have to look at both. So looking at some of the terms, the taxonomy of pain, these may sound familiar: acute, subacute, and chronic. Acute is pain that's occurred less than 30 days for the patient, and subacute is lasting 30 to 90 days. Chronic, usually greater than 90 days, or some definitions will say pain that has outlasted its usefulness. So we already know what the pain generator is, and the pain is continuing even though even the generator of pain has been addressed or cannot be addressed, and the pain continues. There are also, for your information, new ICD-11 chronic pain classifications effective in 2022. They are just being implemented practically in many systems, so this is more informational as you may see them come up. The divisions are chronic primary pain and chronic secondary pain, and underneath each of those topics are 6 types that you can see listed there. And this goes beyond the scope of our time here together, but it does speak to the fact that as the science continues in understanding and researching pain, we're becoming more specific in terms of how we talk about it. So you may hear more about that as time unfolds. What are types of pain, and what is the terminology we use for them? This may sound more familiar than the ICD-11 terms. Nociceptive and neuropathic are commonly understood terms. Nociplastic is a little newer, but nociceptive is any pain from actual or threatened damage to non-neural tissue via nociceptor activation. So what are nociceptors? They are specialized nerve endings that sense pain. If that's their job, to tell you that hurts, don't do that. They are found widely throughout the body, in somatic tissue as well as visceral tissue. And the feeling that the patient experiences from those different locations may be a little different, and we will look at that in a few slides. Neuropathic, as opposed to nociceptive, is any pain caused by a lesion or disease of the nervous system. So these are nerves that are not nociceptors. It's not their primary job. They are not designed to relay painful messages, but they're doing it anyway because of an injury or an alteration in the health of those nerves. Nociplastic is a newer term, but you will see it in the literature, and it's any pain that arises from altered nociception. So this is not neuropathic pain, but nociceptive pain, despite no clear evidence of any tissue damage, and no evidence for disease or lesion in the somatosensory system. Some examples that are now being classified in that manner are fibromyalgia syndrome, chronic myofascial pain syndrome. So again, that is more to come, and the term reflects the idea that the nervous system is plastic and changeable for the better and sometimes for the worse. How do we get persistent pain? We've looked at the terms and defined them, but what are the risk factors and how do we understand persistent pain? It is more than just acute pain plus time. There are things happening in the body that are putting this into play. Sensitization is the main problem that we think promotes persistent pain. So sensitization is basically an increased responsiveness and reduced threshold of the nociceptive neurons in either peripheral or central nervous system. This can be temporary, which would be the preferred event, or unfortunately, it can be permanent. So something happens to sensitize these nociceptors. Peripheral sensitization, we know that the COX enzymes play a role. They convert arachidonic acid to prostaglandins. That increases the sensitivity of the nociceptors and they fire more easily. So the thresholds are lowered for sending a signal from the nociceptors. They'll fire with things that they didn't fire with in terms of a threshold previously, and they can also send ectopic nerve impulses or paroxysmal firing, a burst of repetitive firing and unprovoked. Basically, ectopic is an unprovoked nerve impulse. And there are silent nociceptors that are kind of the Army Reserve, if you will, and they will be activated when things are sensitized. There's also central sensitization, and this usually occurs after prolonged peripheral noxious or painful input. So it starts usually in the periphery, there becomes a sensitized state in the peripheral nervous system, and this may translate then again into the central as those signals are constantly relayed to the central nervous system. We know that there's an increase in glutamate, which is an excitatory amino acid in the spinal cord when we see sensitization taking place. This glutamate also stimulates NMDA receptors, which in turn further sensitize the central nervous system. We do have some medications that target those receptors, which you'll hear more about in another section. And there can be sprouting of non-painful nerve fibers. Fibers that are supposed to tell you about touch and pressure may sprout into the dorsal horn and start transmitting painful impulses. What are the risk factors for getting into a state of chronic or persistent pain? There are potential risk factors that have been linked, and linkage means there's a correlation, not necessarily causation, but this is the research that's telling us these are the risk factors for developing chronic pain. Would always be good to lower those risk factors and prevent rather than have to just respond. Nociceptive pain, what is the physiology underlying that? Briefly, transduction, transmission, perception, and modulation. So the transduction is just taking an injury, whether it's a pinprick or pressure or thermal, and translating that into an electrical message. That's via many neurotransmitters, a chemical soup of facilitators that you see listed there. Transmission is that when the nerve message that's now electrical is transmitted up to the spinal cord. And there are voltage-gated ion channels that allow sodium or calcium to flow in and out, causing an action potential. Perception, these are secondary neurons in the spinal cord are activated, and they send chemical messages to the brain, and pain is perceived here. Modulation is also a very interesting part of this because it's a descending pathway from the brain down through the spinal cord, facilitated with neurotransmitters that help decrease pain. And some of our medications, particularly the norepinephrine reuptake inhibitors, capitalize on that. And so this is just a schematic of that process of transduction, transmission, perception, and modulation, and how they work, and why we can use different medications that target this process at different locations within that process. So how do we compare when we're seeing a patient what their report might look like in terms of nociceptive versus neuropathic? Somatic nociceptive pain is usually well localized, sharp, aching, throbbing. Common causes are things like fractures, cellulitis, trauma, rheumatoid arthritis. Visceral nociceptive pain is diffuse, gnawing, and cramping. So it's not as localized and gnawing, aching, cramping, bowel obstructions, liver capsule distension, pancreatitis. Neuropathic pain has distinct qualities to it, such as burning, sometimes itching, tingling, electrical, sometimes called sharp. Some patients will say it's a numb pain or crawling, as if insects were crawling on you. Allodynia is another big tip-off. It's basically pain from a non-painful source. So if you lightly touch that area of pain and that light touch is perceived as very painful or like sandpaper rubbing on the area, that would be allodynia that alerts you to, oh, this is like a neuropathic type of pain, which would, on our intervention, will then be tailored to that assessment. Also, hyperpathia, hyperalgesia is basically an increased response to a small noxious stimuli. So a finger stick makes the patient jump, 2 feet off the bed. That's an overreaction. And that is not just psychological. That can be physiological due to a neuropathic state. Lancinating is sudden shooting pain. That's typical of neuropathic pains. So if it's a sudden and it shoots, radiates, think neuropathic. And of course, electrical tingling, pins and needles. Neuropathic pain post-op can be overlooked, as of course we expect the patient to have pain post-operatively. But keep in mind, this can happen with any surgery, the best surgery in the world. It doesn't mean anything went wrong. But nerves are stretched, they're compressed, they're cut, they're ligated. Surgeries that are more commonly linked with neuropathic pain are post-thoracotomy, post-hernia, post-mastectomy, and amputations, but it can occur with any surgery. So when you're seeing a patient, post-op or otherwise, consider, could this be neuropathic pain when the pain is greater or longer than expected? Because opioids alone are usually not effective. And if there's a fair or poor response to opioids, as I said in NSAIDs, those two categories of medications are not that effective, at least alone, with neuropathic pain. If there's sudden increases in pain, it's not too bad, and then all of a sudden it just escalates very rapidly. If it travels or radiates, and if there's paresthesia, sensory alteration, or changes such as allodynia, think neuropathic pain. So how do we take all this knowledge, physiology, and put it into a practical manner of assessing patients with pain? Well, of course, the treatment plan all starts with pain assessment. And there's an interesting quote by a pain researcher that's good to keep in mind, that describing pain only in terms of its intensity is like describing music only in terms of its loudness. We need a better, broader, more holistic way of assessing pain than simply looking at intensity. And that's what we're going to look at in this section. So we need to know the pain characteristics. There are many tools available. I just mentioned one, a mnemonic called Old Cards. We'll look at that specifically in a moment. But looking at pain characteristics, function, which means activity tolerance, mood, and sleep, and the type of pain. So those are 3 categories that we need to really assess in order to get an effective plan. Common types of tools to help us with pain assessment can be differentiated as one-dimensional, like only looking at intensity. This is an incomplete picture. We really need more than that. Multidimensional tools look at a variety of components: pain, activity, mood, social engagement, sleep. Most of those multidimensional tools, however, do not include neuropathic assessments. So you still have to keep that on your radar, as you're not going to get that in most of those tools. Specialty tools are also available. There are neuropathic pain scales. There are observational pain assessment scales for patients who are unable to self-report. Of course, we know that self-report is still the gold standard, but not all patients are able to do that, and there's pediatric tools. So here's just a overview, you can find this many places on the internet, of one system to get to the characteristics of pain: onset, location, duration, characteristics, aggravating, relieving, treatments, and severity. So that can be a helpful tool. It's just one of many. You can use whatever tool or system that you have preferred. So here are some more tools just for your information: intensity by patient self-report, the numeric rating scale, verbal descriptor scale, visual analog, and pediatric scales. What are some cautions? These are all unidimensional. They're just looking at pain intensity. Patients often interpret numbers as it makes sense to them. They're not reading the literature on pain management. If they came in with a 10 out of 10 pain because it was the worst they've had, it was terrible, it was severe, and now it's better, they may say that, oh, now it's 8, that's better. But if you ask them in words, they may say, oh, it's medium. So we can easily miscommunicate. And generally, words are more commonly defined than numbers. So make sure that you verify your numbers with words. Also, other cautions to keep in mind: that self-report can be influenced by catastrophizing, this emotional reaction of thinking the worst, it'll never end, and just feeling in despair. That may raise the score because the score may be part emotion and part physical. Influence of the score by individual attitude. Sometimes patients are afraid of treatment withdrawal, and so they may report higher numbers because they're afraid if they say they're better, you won't give them anything. Sometimes people may report lower numbers because they're afraid of the treatment. And sometimes patients are dissatisfied with care, and that may influence what they report. So there's a higher risk of over or under treating pain when you base your assessment on intensity alone. We need more than that. So where the recommendation is to use intensity and function in terms of scales and tools, or use a multi-dimensional scale to improve accuracy of assessment. What is a functional scale? Well, this measures the effect of pain on passive and active activity. Some examples of that are the PEG tool. It looks at pain, enjoyment of life, general activity, brief pain inventory, looks at a number of factors: intensity, relief, activity. There's the Defense and Veterans Pain Rating Scale, DVPR, that looks at pain and activity interference. There's something called Clinically Aligned Pain Assessment, or CAPA, that looks at a 5-item assessment of comfort, pain, activity, sleep. And there's a McGill Pain Questionnaire, used more in research because it's lengthy. It's a 78-item device. There are also observational scales. Not every patient can self-report, let alone accurately. They just are not able to self-report due to altered mental status for one reason or another. So these observational scales are helpful, but they have to be understood for what they are telling you and what they're not telling you. It is a measure of the likelihood that pain is present. It cannot measure intensity as with self-report. We do not have a mechanism to do intensity when someone cannot tell us. With adults, there are a number of tools: Pain Ad, CPOT, Comfort, BPS. Pediatric also has tools designed for specific age groups. There are some scales that can be used for both. But do beware that there is a number of studies showing that observational tools or surrogate, a parent or a family member, assessments often underestimate self-reported pain scores when they're able to compare both. Neuropathic pain scales are specific questions, sometimes with an exam, that identify neuropathic features. There's LANSS, the LANS, and then there's an SLANS, which is a shorter form that the patient fills out and is shown to be equally reliable. I just want to show you some examples of some of the tools that are available to you. You do also need to be aware of copyright rules. So if you want to adopt these in a written fashion, you can look that up from the authors of these scales. This is the original functional pain scale, 0 to 10, but it goes by 2s. There is a revised version for hospitalized patients that is also available. This is an example of some pediatric pain tools. I know there's a lot and it's hard to read, but this is just to show that there are choices. Behavioral observation tools. There are self-report tools. And then there's patient or caregiver reports that can also be used. Here's what the PEG tool looks like. It's considered a multidimensional tool, and it's only 3 items, which makes it popular for busy clinicians. What numbers describes your pain on average in the past week, and 2, what number best describes how during the past week pain has interfered with your enjoyment of life, and then how has pain interfered with general activities. So given that they're asking for an estimate over a week, this is better for outpatient assessment and management. Brief pain inventory is another tool that's used by researchers and many centers. It does have a copyright on it, so this is just an example. And it does look multidimensional in terms of pain intensity, as well as how pain interferes with activity, mood, walking, etc. This scale is available without any copyright limitations, as long as you don't alter it. This is from the Department of Defense, and it does look at pain and interference with activity. Here is what the LANS pain scale looks like. It is asking questions on the left, and then there's a brief exam, sensory exam, looking for allodynia, as well as altered pin prick thresholds. I think it's instructive to look this up and integrate the techniques that it's looking to teach you in terms of sensory testing, whether you use this formally or not. There is a short version that is listed here. This is the SLANS. The patient fills it out, and they actually instruct the patient how to do a brief sensory exam, not with pinprick, but with light touch. And studies have shown this is good correlation, so that may be simpler. This is what the CAPA tool looks like: comfort, change in pain, pain control, functioning, and sleep. This has been modified. University of Minnesota uses this. The blue writing in the middle of the tool is the original, but University of Minnesota has permission to alter it. But basically, this is interesting because the principle underlying this tool is that pain assessment is essentially a social transaction that requires conversation to assess properly. And there are institutions that have adopted this for their inpatient as well as outpatient assessments. And it can be then linked to numbers and quantified in a documentation program. And once staff have been trained in it, they've usually been satisfied, and patients find it more engaging and more helpful than just what's your number. And so there are tools out there worthy of exploration. Remember, we have a dual crisis of pain and opioid overdose. Both need to be addressed if we're going to be effective. We need knowledgeable providers, and we need action to decrease the risk of chronic pain as well as the risk of overdose. We need to know pain taxonomy and evaluate for the types of pain in order to be effective. We need to understand nociceptive and neuropathic as well as nosoplastic. How can we identify neuropathic pain and intervene when we're having trouble with patients' pain control? And we need to conduct a thorough history, physical exam, as well as a diagnostic workup. And of course, establish a pain diagnosis, treat whenever possible. Don't just dismiss it as psychological. Do a thorough workup and include a holistic evaluation. The patient is not just a body. It's a biopsychosocial, spiritual evaluation. We can find those tools that can be doable to help us with that. And SUD, substance use disorder screening, can be informal or formal, but we do need to have that on the radar and to have that in our evaluation. Again, differentiate opioid misuse from OUD, educate the patient, enroll with ILPMP, choose reliable assessment and screening tools, understand what each tool measures and what it doesn't. So put this together in your toolbox for safe and effective pain management, because that is possible with an informed provider that's using the resources that are available. Thank you very much.